Okay, benign prostatic hyperplasia, BPH. First of all, I think we need to describe the male urinary system in order to understand this the problem here. Over here in this picture, we got the bladder, right? Bladder. We come down here with the urethra. Prostate's right here. Seminal vesicle is off to the side there, which isn't really anything that we'll be talking about. I'll go ahead and make this prostate here kind of brownish. I don't know. I don't know what color the prostate actually is, but I always think of it as brown because they always say that it's about the size of a walnut. This kind of thing. You know, walnut's brown, so prostate must be brown. May not be. Who knows? But anyway, we also got the rectum, and I probably should have drawn that in here. The importance of, you know, the rectum is kind of coming right across here, right? Right. So that way, it's kind of C-T-U-M. Important to know that because that's why the doctor can go ahead and do a digital examination right up through here and palpate the rectum and feel if it's enlarged or if it's smooth or whatever. Be enlarged and smooth if it's benign prostatic hyperplasia. It will be kind of rough, and you can feel some rough patches. We'll see that when we look at our PowerPoint slides. Anyway, what happens with benign prostatic hyperplasia is the prostate here gets enlarged, and the reason we really have a problem with that there is because this here on the edge here, it's encapsulated in a fibrous. They call it a fibrous capsule. Right? And because of that, there's not a whole lot of give to the prostate. I'm going to keep that in the picture here. So anyway, we do not really have problems with the prostate enlargement in males less than 50. But by the time they get into their 50s, they have a 50% chance. So 50% of the males in their 50s do have benign some hyperplasia going on there. And then when you get up to your 80s, it's 80%, so that's pretty easy to remember. So I guess if you get to be 100, you're 100% sure. I don't know about that, but definitely the older you get, the better chance there is that you are going to have a problem with prostatic hyperplasia. Okay, we need to talk about the pathology of BPH. The problem with BPH is male can't pee, right? Got urinary retention. That's our problem. The reason we have that problem is because we get this enlargement of the prostate here. The prostate enlarges. It's encapsulated in kind of a fibrous cap here, so it doesn't have a lot of give. Now, it's not like the cranial vault, where there is no give at all and you get increased intracranial pressure. This here, but it is rigid. It's not really elastic. So the fact that it lacks this elasticity and this ability to grow easily, and when you get the overgrowth of the cells in here, you end up with a lot more pressure inside the prostate. So as it will grow and it will get larger, and that will be able to be palpated by an rectal exam, and to be able to feel the enlargement here on the prostate. But as it grows out, like this, and you get that pressure going out like that, you also got pressure going in, right? You're going to have that pressure going in like this. Ouch, right there. So as it pushes in like that, what's it doing? It's putting pressure on the urethra, right? It's pushing in on the urethra. So by pushing in on the urethra here, you are losing. You're going to be able you're going to be causing urinary retention. That there will cause urinary retention by itself, but then we have another problem going on here, and that is that you're getting this pressure going up on the pre-prostatic sphincter, which is right here. It kind of stimulates that prostatic sphincter and causes it to have an increase in tone, so it can't relax well for the person to be able to urinate well. So that's really the problem there. Nobody knows exactly what causes BPH. What we do know is that the prostate cells are hypersensitive to the androgens as a male gets older. Androgens are the male hormones. Of course, testosterone is the main male hormone. But androgens' effect on the prostate cells, they do is they stimulate reproduction of prostate cells. Testosterone is one of these androgens, and the other one is affecting that we need to talk about with the prostate anyway, is, what is it, dihydrotestosterone, DHT. DHT is what we'll call it, what everybody calls it. So, and that's another androgen with a much stronger effect than testosterone, at least as far as the effect that it has on the prostate cells. It's up to 10 times the effect on the as testosterone has on the prostatic androgen receptors. The fact that the androgen receptors of the prostate are hypersensitive stimulates an acceleration of prostatic growth. Now we know that DHT has a more potent effect on the prostate cells, but where does the DHT come from? That's the question. The answer to that question is what will explain some of the medicines that we use for BPH. DHT comes from testosterone. There's a hormone called 5-alpha reductase. 5-alpha reductase. We got testosterone. And this 5-alpha reductase acts on it, and we end up with DHT. So, we need the 5-alpha reductase to convert to testosterone to DHT, and DHT is doing most of the damage because, like I said, it is 10 times as potent as testosterone, at least in its effect on the prostate's androgens. We have a medicine, and they are 5-alpha reductase inhibitors. So 5-alpha reductase inhibitors. So, name of them tells you exactly what they do, right? They stop this action. They stop the 5-alpha reductase from acting on the testosterone. Therefore, they stop or decrease the amount of DHT being synthesized. And what this does, this stops the conversion of testosterone to DHT, and the hyperplasia is halted. In fact, not only is the hyperplasia halted, the prostate shrinks. So it actually reverses this hyperplasia of the prostate. It takes as long as 6 months for the patient to have noticeable improvements. You can look on page 1271 in your book, and your Med-Surg Lewis 10th edition book. And it has an explanation on this medicines, and the main one, finasteride. Finasteride. That's the main one there. Another thing to look at right there on the other page there, 1270. It has the American Urologists Association severity scoring thing there. That could be helpful for you to know that. And then there's another group of medicines that I want to talk about, just one other group here, but really, if you remember when I was talking, not only did I mention the fact that the growth of the prostate puts pressure on the urethra, and that impedes urinary flow. It also puts pressure up here on the pre-prostatic sphincter, and the pressure it puts there, it ends up causing irritation and causing the sphincter to be spasmodic and kind of clenches down, and it's hard. It causes urinary retention. These men with that problem usually they have that much for a long time before they actually get to the problem in the urethra itself. And what they have is they'll have a difficulty starting the stream. Kind of a common thing that will go on for several years usually before they actually have a real big problem with the urethra itself. But anyway, there's a medicine that we can give for that, and it's an alpha-1 adrenergic receptor blocker. You might think, why are we using an alpha-1 receptor blocker for this? Alpha-1 blockers, we think of them like with hypertension. But in this case here, what we're doing, what it does is, well, first of all, you got to think, what is an alpha-1 adrenergic receptor, right? What is that receptor? It's an adrenergic receptor. Adrenergic, adrenaline, right? Epinephrine, adrenaline, same thing. So the fact that it is an adrenergic receptor will tell you that this is part of the fight or flight nervous system. The fight or flight, what is that? Right? The bear comes through the door, I get scared to death, I take off running, right? My heart starts beating, everything starts going. Do I want to pee at that time? No, probably a good idea to increase the tone of this sphincter. Increase the tone of that sphincter so that, because we don't want me peeing now, I'm not going to stop and pee while I'm running away from this bear. I can wait and pee when I can finally calm down and relax, right? Once I get away from the bear. So that's why, and that's what the alpha-1 adrenergic receptors do. They stimulate this pre-prostatic sphincter to contract, and they increase the tone of that sphincter. So by giving a blocker, it decreases the tone of that sphincter. In other words, it relaxes that sphincter. So by decreasing the tone of that sphincter, the person finally has a better chance of relaxing and starting his urinary stream when he needs to. And let's see the main one there. Now we talked about 5-alpha reductase inhibitors, right? Now we're talking about alpha-1 adrenergic receptor blockers. All right. Now these guys do not shrink the prostate. These guys shrink the prostate, right? These guys don't. These guys relax the sphincter. In fact, these guys can be used for these alpha-1 adrenergic receptor blockers can be prescribed for women when they have a urinary retention problem. You don't see it very often because you don't see women with urinary retention problems very often. But you will see that. Yeah, it is something that happens, and you will see those. You won't see these guys, right? You're not going to see the 5-alpha reductase inhibitors given to women because they don't have a prostate to shrink, right? But they do have a sphincter to relax. So you might see them with that, well, to relax the sphincter, but you're not going to see the 5-alpha reductase inhibitors because they don't have a prostate. I guess I don't need to talk about that anymore, huh? In the medicines here, these guys here, the big one is tamsulosin. I'm sorry, Tamsulosin, and the brand name Flomax. Right? Helps them flow. It maximizes their flow. Yes. And you will also find that one on page 1271. Right, and it'll give you some more, meds. I just kind of mentioned the main ones, the ones that I see, that I have seen out there a lot. But they mention a few other meds there that are in those same groups, and as far as I know, they work just the same. And I think that's about all I have to say for right now. Look at there in your book is the chart there. On page 270 or 1270 on the American Urologic Association severity scale thing that they have on there. That's a nice thing to know. You can look at that, and that will a lot of times determine which course they take as far as treatment goes. Because the treatment is usually, sometimes they just want to watch. They'll just watch them, and they'll have the person, if it doesn't bother them, it's not a problem, right? The person should be taught to make a conscious effort to don't drink right before you go to bed, right? Don't drink a lot of alcohol, especially. Don't drink a lot of caffeine. Don't drink anything that's going to make you want to pee, because that's one of the big problems that you have with BPH, is that the patient is complaining that he's got to get up 3 or 4 times during the night. Well, because his bladder never empties. When his bladder never empties all the way, it stays so full. It just goes from being real full down to about halfway, and then it goes up there again, right? So he never actually gets to empty that full bladder. So he's got a retention polyuria. So with that being a problem, you try not, in order for the person to get some sleep, you try to not to have him drink too late at night. Well, I finally got that damn thing done. It ain't pretty, but the information's on there. I'm pretty sure most of the information's on there anyway. Hopefully this will help you, and hopefully we can get this going. I can learn how to do these a little bit faster. I wasn't really doing a great job at it. Just kind of had a hard time getting it all on there. Probably repeated a lot of stuff. I had to do it a couple of times. Now I have to go in there and try to what do they call, edit it. I don't know. I ain't going to do a whole lot of editing. I'm just going to kind of put it together. You guys will, it don't have to be pretty. You guys will be able to see it. This is my first attempt. What the hell? It'll get better as time goes. Good luck on getting this information down, and I'll see you guys later in the week. Bye.